Hello, everybody and friends in Latin American Endoscopic Spine Surgery Society. Thanks a lot for having me in the great web meeting of EndoRaquis today. Also, I really appreciate the support of Real Spine. My talk today is the impact on sagittal and coronal alignment following the endoscopic lumbar decompression. Considering the current level of evidence, it is hard to pinpoint exactly how the endoscopic decompression has an impact on the sagittal and coronal alignment following the endoscopic laminotomy or other sort of endoscopic procedures yet. However, I'm gonna circulate my experiences through my patient results with you all guys. When I end this up today, I hope you are motivated with a great passion for learning endoscopic spine surgery and keep you continue your effort to be an expert of endoscopic spine surgery. Okay, let's move on to the contents today. This is my disclosure. I'm the consultant of Real Spine. So sometimes asked, I have a question to myself. Endoscopic decompression is better than the conventional open decompression? And can the endoscopic decompression procedures really reduce or delay the spinal fusion or minimize chances of secondary surgery? Eventually, could the endoscopic decompression procedure be the standard procedures in spinal stenosis? That's the question, not only to myself, but you all guys today. You think about the spinal disease and the treatment. I always have been thinking of the what gonna be the best treatment considering all the way of the chronological order in the patient. Initially, patient usually have the disc problem, herniation, disc degeneration, and facet degeneration hypertrophy, and sometimes recurrence disc herniation with aging process. A patient usually have the central and foraminal stenosis, and finally, degenerative spondylolisthesis and sort of instability there. And considering the chronologically order, we offer endoscopic discectomy, foraminotomy, and laminotomy, and MIS fusion eventually. So this is contents today. We have the endoscopic tools, discectomy tools, and the decompression tools. And I'm going to circulate case-based running today, but I cannot circulate all the procedures. I just focus conventional subtotal laminectomy and pros and cons of endoscopic decompression, discectomy, and foraminotomy, and impact on the sagittal and coronal alignment accordingly. I have, this is prologue. So I have the two patients. Exactly, they are same age, 37, female, and you can see the MRI finding, degenerative spinal stenosis, having the both sciatica and claudication at the same level, same symptom, same gender, same age, right? So what gonna be your ideal suggestion plan for these two young female patients, right? So I operate this patient, case one, by the open laminectomy, by classic manner. And the case two underwent endoscopic ULBD, right, by myself. So I gonna circulate the follow-up outcomes. This is case one. Because I'm practicing the university hospital, I need to teaching my resident and fellow with the basic surgical procedures, conventional open and microscopic and endoscopic as well. This is a case of the subtotal laminectomy, classic manner. I did the operated And you can see the post of MRI well and perfect decompression with the bilateral resection of facet joint, medial side. But clinically, patients so clinically successful outcome there, but you can see the angular instability just 6 months follow-up post-operatively. That's the problem. This patient might more chance of the sort of the instability in her chronological age, right? This is the second case of the 36, 37 years old female. I operate this patient with the full endoscopic ULBD approach in left side. You can see the perfect decompression at the index level. And what about the follow-up status and radiological and clinical outcome? You see the improvement whole lumbar lordosis and segmental lordosis as well. I personally have thought probably by endoscope with minimized tissue damage and maximize the preservation of normal tissue, it works really good in the patient long-term outcome. I'm gonna circulate some cases from my practice. This is another example of open subtotal laminectomy 4-5, right? Patient have the no spondylolisthesis there, just have the spinal stenosis. What about the follow-up X-ray open decompression? Even the 3 months, just 3 months, you can see the slight slippage, aggravation of spondylolisthesis. What about the result of 3 years? Yes, patient have the occasional back pain and buttock pain right now, and she probably will be getting the lumbar fusion within a couple of years, right? That's the drawback of the subtotal conventional resection of the problem. This is post-op 1-day MRI, perfect decompression, but the follow-up MRI, you can see the recesses, slippage, and subsequent foraminal stenosis. This is the other case. Even though we have the great, well-maintained sagittal alignment following the subtotal open laminectomy, this is a patient who had been enrolled with the randomized control trial. 1 year follow-up MR X-ray, it looks great, but when I check the MRI in this patient, you can see you can compare the post 1-day MRI and 1-year MRI, left and right side here. You can see the this kind of the adhesion, some sort of suggesting finding suggesting adhesion and epidural scar. Yeah, this patient, considering the finding of MRI, this patient have restenosis, adhesion, pending recurrent symptoms, right? This is another case of following the open subtotal laminectomy for file level. Initially, she had been suffered another many kind of the medical comorbidity and end-stage renal disease and the atrial fibrillation and the post of the cancer, etc. Patient had been suffered the right side dominant claudication. You can see the central stenosis and lateral subluxation at the profile level. So at the time, 6 years back, I did the conventional subtotal laminectomy at right side, 4-5 and both sides, and 5S on right side. So you can see the serial X-ray, post-op X-ray 2 years follow-up. There's a definite aggravation of spondylolisthesis. So patient had been suffer from recurrent symptom of back pain and buttock pain and other pain as well. So I did the lumbar fusion with the olive surgery at the profile 2 years ago. And this is follow-up, recent follow-up X-ray, patient clinical symptoms nearly free, near normal daily activity there, right? So I can circulate this sort of the lesson from the conventional subtotal laminectomy. That's it, the removal of posterior structures uh, with the supraspinous ligament, bilateral facet resection, and muscle damage, especially multifidus muscles, and epidural scar there. This makes iatrogenic spondylolisthesis, loss of rhodosis, back muscle weakness, etc. Eventually, this sort of the conventional open subtotal laminectomy increase risk of lumbar fusion. So what about the cases of follow endoscope? Can you get the different clinical and radiological outcome with the endoscope? Just see the MI case. I'm gonna circulate the first case, impact and lumbar endoscopic ULDB over the top on the spinal alignment in the simple lumbar spinal stenosis. This is the 69 years old male patient. You can see the perfect decompression on left side, over the top decompression, and patient 17 months follow-up whole spine X-ray. You can see the alignment improvement, sagittal much more rhodotic curve. It looks like we did the lumbar fusion, right? So perfect, ideal, very nice decompression, especially in the endoscope tool. We can also get this kind of the restoration of the lumbar lordosis, right? That's a message from this case. What about the other case of impact on lumbar endoscopic ULBD and spinal alignment? In case it's grade 1 low-grade spondylolisthesis combined with spinal stenosis. This is very interesting and valuable case. Patient 68 female patient and claudication, dominant uh, right side and left side, claudication, back pain and leg pain as well. You can see the grade 1 spondylolisthesis at 3-4 level and disc height loss and 4-5 and 5-1 as well. So in the case of multifactorial MRI finding from 3-4 and 4-5, 5-1, some guys may prefer the multi-level fusion from the L2 and 5-1. But considering the patient or the MRI and clinical symptom, we need to find the real pain generator from the patient, right? So this is a pre-op MRI and post-op CT scan there. Please pinpoint exactly the facet joint, the resection margin of the dashed yellow area. That is the bony resection area done in this patient. So by this endoscopic surgical skill set, we can minimize the violation of facet joint less than 10% overall, right? That is true. So what about the follow-up X-ray in this patient? You can compare, you can see the definite improvement, not only rhodosis, but also spondylolisthesis, a very challenging, interesting finding there. We haven't seen this kind of the restoration of even in the spondylolisthesis. So I have thought, what gonna be a real causes finding these, right? Right. So my hypothesis of this improvement. So before the operation, patient had the claudication and pain, but after decompression, patient uh, didn't have doesn't have any kind of the pain and claudication. Ambulation and exercise will improve. That improve makes the improvement back muscle and motor rotatic curve improvement. Eventually, it makes the improve the spondylolisthesis ever, right? This is the 1-year flex and extends X-ray there. So I'm gonna circulate. This is not a single case. I have seen this kind of the improvement in actually the most of the patient who underwent endoscopic decompression in the degenerative grade 1 spondylolisthesis. Just this patient, unique patient. Patient have the cystic changes at the midline with the spondylolisthesis. Patient also have the medical uh, comorbidity in the rheumatoid arthritis and the breast cancer, etc. So patient have the underwent full endoscopic translaminar resection of ligament FLAVUM cyst because the location of the ligament FLAVUM cyst just inside the spinal midline exactly, right? So I successfully removed the ligament FLAVUM cyst without any damage of facet joint. That's the key of the spinal, this case. 1.5 years follow, you can see the better restoration, no aggravation of spondylosis. Back pain 0 and leg pain 0 fully return to daily activity, and recovery rate patient reported outcome is 95% in this patient, right? Let's move on the more octogenarian case. Actually, this patient has 80 years old female patient. Patient have the right side dominant buttock pain and leg pain, claudication less than 30 minutes, 30 meters, right? Just see the patient have the little bit kyphotic posture because we don't know exactly in pre-op status, probably the pain or the spinal stenosis. Patient had the huge hypertrophied facet joint in right side and radialis decompression as well. This is pre-op CD. So I usually prefer the en bloc resection of ligament flavum. I don't like the piecemeal removal of ligament flavum. If I've chanced to talk more later, I'm gonna circulate the technical point of view of the en bloc resection of ligament flavum. Anyway, you can see the perfect remodeling of the MRI. So uh, we usually used to have the just the simple goal. That was the decompression alone. Nobody, everybody know the we should make the perfect decompression. That is the first goal. But when I follow this kind of patient with MRI, I have found the very important interesting lesson from the patient. That is a secondary goal in this kind of the endoscopic decompression. Even the facet fluid there, facet inflammation is related with the instability and pain, right? Just see the follow-up MRI, facet joint fluid subsided completely, right? Preserved facet joint, that might be related to the fast back muscle as well. Okay. So what about the segmental and whole lumbar lordosis? It looks like the lumbar fusion effect, right? A dramatic improvement as segmental and whole lumbar lordosis. Also the decrement of the segmental spondylolisthesis as well. This is a truly important message of today's my talk, right? So what gonna be the lessons from the endoscopic over the top decompression, not only in the spinal stenosis, simple, but also in the case of degenerative spondylolisthesis. That is the our by the endoscope we can preserve the postural structures, supraspinatus ligament, facet joint, and back muscle, and little epidural scar there. So that makes subsequently free of claudication, ambulation will improvement back and muscle power. Eventually, it makes improvement lumbar lordosis. Eventually, it makes the improvement spondylolisthesis as well, right? What about the cases other following the endoscopic discectomy? I'm gonna briefly introduce this kind of the case. Old age 37. You can see the coronal and sagittal distortion like that. So I have done endoscope, perfect restoration, coronal and sagittal alignment as well. And also the follow-up MRI, perfect remodeling of the disc and annulus as well. These high school students, young adolescent patients sometimes, patients have the bilateral sciatica and underlying lower back pain as well. You can see the high canal compromise, fecal sac. I've done the transform endoscopic discectomy in this patient. What of the follow-up 1 day and 1 year MRI? You can see the serial remodeling of the spinal canal with the remodeling of the annulus. So what about the impact of transformer endoscopic discectomy on sagittal alignment? So left side, you can see the patient whole spine X-ray. It looks like deformity kyphotic changes. You probably need the deformity multi-level fusion in the high school students. No, just treat the patient, the real pain generator. Then we can get the aligned, beautiful restoration of the sagittal and coronal X-ray, right? Let's move on to other patient. First episode is also this high school students when she was 17 years old. At the time, she underwent microdiscectomy and recurrent and microdiscectomy again, and the third time recurrence. And then she visited me at the time, 2020 last year. This is pre-op X-ray and post-op X-ray at 6 months follow-up. And what about the 1 year follow-up X-ray? The beautiful restoration of sagittal alignment. So whenever she visit my clinic, she shout, "Hey, professor, I love you so much," because her mother also got the surgery by me for spinal stenosis as well. Let's move on the final and a little bit the interest. What about the multi-level fusion? I agree, totally agree. The endoscope a little bit time-consuming procedure rather than the compared to the open surgery. So currently my strategy for multi-level spinal stenosis, complicated foraminal stenosis like that, I prefer the hybrid MI decompression with the endoscope and microscopic tubular approach. Just see this female, 80 years female patient had the claudication, mostly right leg dominant pain. You can see the very much multi-level problem from 2, 3, and 5 on, and multi-level foraminal stenosis, especially 4, 5, and 5-1, not only foramen, but radialis decompression. Yes, this patient usually good indication of multi-level lumbar fusion, right, from 2, 3, and 5-1 to iliac screw as well. But if you have special surgical skill set with endoscope and microscopic surgery, you can solve this kind of a complicated spinal problem with the different sort of the mixed hybrid surgery using the microscopic over the top S3-4 level transforaminal endoscopic foraminotomy and radialis decompression at the 4-5 level with the single shot to treat the kill the two birds by the single stone. Also, 5-1, we had the same strategy, the transforaminal tubular microforaminotomy and the radialis decompression. You can see the perfect decompression at pre and post-op CT scan because of 5-1 has patient have the very severe high-grade hypertrophied facet and radialis decompression. In this case, sometimes we need to do the additional pediculectomy for access radialis decompression as well. This is 3-4 and 4-5 foramen and the 5-S1. And what about the alignment changes? This is important message. Even in the old, nearly 80 years old female and cases multi-level foramen and central stenosis, yes, we can treat this kind of patient with the minimized MIS endoscopic tool, getting the beautiful restoration of sagittal alignment. So take home message. So what's gonna be your takeaway is from my talk today? So the conventional subtotal laminectomy is good for beginner. I'm gonna still do this kind of surgery because of my teaching, but actually, for my personal opinion, please kick out this in your practice, right? This kind of conventional subtotal bilateral approach usually eventually make the iatrogenic spondylolisthesis. So don't do that in your patient. So endoscopic over the top. By this, we can get the same clinical outcome better regarding the posterior structure, probably better regarding the long-term outcomes. So what about the transforaminal endoscopic discectomy? Actually, this is the best procedure ever for disc hernia, L2-5 and L5 in case of low iliac crest. In case of multi-levels, please adopt the hybrid MIS endoscopic approach because we need to consider time-consuming issue that. Thank you very much. This is my talk today.
Thank you so much, Professor Kim. It was really a topic that we all have question about it. It's a really everyday question if you should fuse or not fuse a patient with a stenosis and instability or stenosis and listhesis. So I have a question for you.
Yeah.
We see we saw in your presentation that you did surgery on patient with air in the disc, with listhesis, with stable listhesis. So not so far ago, the air in the disc and listhesis were like warnings that you should fuse the patient, radiological warnings that you should do a fusion in those patients. So my question is there any radiological sign that you follow to fuse the patient, like a synovial cyst, listhesis grade 2 or maybe higher, or maybe air in the disc? Do you have any analysis on the radiological findings that tells you that you should fuse it instead of only decompression?
Yeah, that is the excellent questions. But unfortunately, we still we don't have the enough evidence for that. And for my private point of view in my clinical experience, Raquis air density in the intervertebral disc itself, sometimes it gonna be one of the indication of lumbar fusion. But I usually try to find any sort of the actual instability in the dynamic X-ray. Also, the correlate any symptoms, clinical symptom related with the air density in the spinal intervertebral disc. Mostly, yeah, mostly we don't find actually in my real practice, considering the patient age and the patient clinical symptoms. Of course, I'm gonna do the decompression alone in most cases, but some patient, if the patient have the definite clinical correlation with the actual pain, with angular instability there, I recommend the fusion surgery accordingly.
Great.
We're
So
still
you
short
follow,
of the evidence, right? That's the problem.
so you follow the clinical signs and you follow the actual
Yeah.
instability in dynamics X-ray. Okay, thank you so much.
Yes.
Hi, Professor Kim. Thank you for sharing your knowledge. Patients with lumbar stenosis tend to bend forward to relieve their symptoms. You show us that with endoscopic decompression, you can improve this positive SBA. My question is, do you use any cutoff in the preoperative spinopelvic parameters to distinguish which patient will improve with this kind of decompression?
Yeah, that is also a very excellent question. So in case of the when we have a planning of lumbar fusion, so in that situation, spinopelvic parameters is truly important for prediction and prevention of the further adjacent segment disease or symptom improvement. But personally, I believe the lumbar parameter in the preoperative, in case of the symptoms, especially newly developed symptoms, radiating pain or the claudication, etc., it is truly overestimated in most cases. So when the patient, even the patient have the kyphotic and the changes and coronal displacement, so that in most cases that is truly related with the pain itself. So when the pain is gone, so patient usually have the return to normal alignment, right? So I think uh, I think when you're planning the decompression, we can consider more pain rather than the radiology finding in most cases. Right?
Thank you.
Professor Kim, I think we have a question from an old friend of yours, David Del Curto. David, ¿estás ahí?
Yes, I'm here.
Hi, David.
First of all, congrats for your presentation, Dr. Kim. As always, you
Thank
are
you.
really academic. You're great presentations all the time since I was your student. So congrats again. Listen, some guys, even in AO education, people sometimes they say about the alignment of the facet joints whenever they align with the sagittal planes or to the coronal planes. So do you consider this anatomy of facet joints when you perform your decompression?
Right. Sure. That is I always see the facet orientation called facet tropism. In the case of sagittal vertical oriented facet joint, that is the patient have the little bit higher risk of the spondylolisthesis following the decompression. So anyway, we can say that by the endoscopic tool, we can minimize the facet violation rather than the micro and open surgery. But personally, one of the previous submitted article, I have a little bit the better preservation of facet joint with the endoscopic procedure compared to uh, micro decompression, but it was not the uh, really different. But I think that is the one kind of early experience of surgical endoscopic experience. So recently I tried to my best, a little bit more than before, to preserve facet joint, even in the vertical oriented facet tropism, right? But we cannot prevent 100% of the iatrogenic spondylolisthesis, regardless the sort of the decompression tool. But as a surgeons, my message is that we try to our best to preserve the facet joint. That is the most important factors to delay the any sort of the further degeneration, any chance of the lumbar fusion surgery.
Great, great. I agree with you. Thank you very much.
Thank you. Thank you so much.